As we move into the second session, the format for the conference, this edited book metaphor that we're using, is going to become very clear to you because no single session bears the burden of our conference, and you'll see the build. It's my pleasure I'll just introduce our moderator, but I'm going to steal the introduction from Carolyn Clancy, who once introduced Brent James by saying, well, you know, this is a person who, you don't have to say a second name. It's like Madonna. You can just say, it's Brent. Okay? So that's what it is. Here's Brent.
Thank you, and special thanks to Helen Burston, Stephanie Glier, and Bob Berenson for taking the time to participate in this today. We've been preparing offline at a fair degree. I was going to introduce each of them. I don't. All of their credentials are up on the slide. Let's just get to it, if we could. Our purpose was to be a little bit provocative, to have a good debate back and forth and try to balance the group to that end. I sometimes think that the most truth comes when you have somebody who's willing to anchor one end of a debate. I often do it even though I know that I'm not going to hold to that long term, just to get the truth out on the table a little bit. It's my job to kick it off. I've asked each person to take 15 minutes maximum. I recommend we come up here because we all have slides, and it'll make it a little bit easier with the slides if we care to do it that way. Well, just to get started, yeah, nothing to reveal. This is a real event. You know, when we published Erich Schumann kicked off the patient safety movement, we estimated 44,000, 98,000 preventable deaths per year. The 98,000 came from the Harvard Medical Practice study that Troy Brennan and Lucian Leap led. Overall, that showed a 3.7% injury rate. 3.7% of patients had at least one care-associated injury during their index hospitalization. We replicated Harvard Medical Practice study in Utah as part of a big Hartford Foundation grant. It was called Utah, Colorado. 2.9% of patients had a care-associated injury in that almost perfect replication. Colorado, we threw in a few hospitals from western Colorado to get our sample size up compared to New York State. Well, years passed and we came up with a new method. We came up with far better methods for detecting patient injuries. Summarized this in a Health Affairs article some years ago. Participated in that one too. The IHI Global Trigger Tool is the current state-of-the-art for detecting care-associated injuries. We got dramatically different injury rates, not 2.9%, not 3.7%, 26% of patients had at least one care-associated injury in the IHI Global Trigger Tool application at 3 big national standard-setting patient safety hospitals, all academic institutions. 26%, and they're real, just as real as they could possibly be. We used to sometimes think, well, maybe just these other methods were missing trivia. No, these were significant events. One thing, for example, Roger Rassar and I took one of the hospitals of the 3 that we assessed. We took what would have been Joint Commission sentinel events, care-associated deaths that would have met criteria for Joint Commission reporting. We had a valid random sample we extrapolated to a full year. At this particular hospital, they should have reported 132 Joint Commission sentinel event deaths in that single year. The actual numbers in the region, yeah, the Global Trigger Tool found extrapolated to a full year 132 events. That year, the hospital reported 9. In reporting 9, they were the highest reporting hospital in the region. The entire region reported 36 events. In the entire region. The for-profit hospital competition to this big academic center among 13 major hospitals had 0 Joint Commission sentinel events. Turns out that in this particular region, it was state reporting requirement. And I was able to go to the state people and find out exactly how many were reported along the way. Now, imagine you're in that circumstance. Imagine you're the administrator of this hospital and you've just been given a new tool. A new tool that bumps your reported hit rate for care-associated preventable injuries by a factor of about 15. What should you do? You face one of those defining decisions, don't you? If you report, what will happen to you? if you report those numbers, well, thank you, you're a stand-up kind of a guy. We're going to completely trash your reputation in the press. And, oh, we have some very significant multi-million-dollar penalties associated with this. Thanks for being honest. See the problem? It's not a level playing field at all in terms of quality reporting. Should the hospital deploy this tool? Of course, I actually can make a pretty compelling argument. You do manage what you measure. By and large, if it's invisible to you, you can't really manage it. It dramatically changes your approach. When you start to bump your hit rates by a factor of 10, a factor of 100, in terms of the data that you collect on one of these events, you're trading off the lives of your patients against your public reputation through mandated measurement systems. You see, what's more important to you, your public reputation versus the lives with which you're entrusted? Now, currently about 150 different groups rank hospitals in the United States. Even when they're looking at similar sorts of metrics, they get dramatically different results. I can drive around in Utah, and every hospital has a big vinyl sign-up, usually saying we're number one. Have you seen that phenomenon? Well, it has some degree of legitimacy. Just to take two of the more famous ones, Truth in Advertising. I serve on the board of advisors for U.S. News and World Report in terms of their metrics, their risk adjustment metrics. 20 honor roll hospitals on U.S. News and World Report stacked it up against the CMS star ratings. Of the 20 best hospitals in the United States of America, according to U.S. News and World Report, one of them, Mayo Clinic actually, had 5 CMS stars. 9 of them did pretty well, 4 stars. On the other hand, 9 of them had 3 or fewer stars. There is no correlation here, just in passing. A more fun way of looking at it, Paul Ketley, back when he was at Deloitte, he's back at Vanderbilt now, of about 4,700 acute care hospitals. He had his interns go and find many of these ranking agencies like to identify the 100 best hospitals in the United States, the 100 best hospital lists. He said, okay, how many of them were on a 100 best hospital list? Well, 1,428 of them were. That's 31% of all hospitals in the United States are in the top 2% of performers. Now, you know the Lake Wobegon effect, that all of the kids are above average. A relatively low standard. I would argue if I can get 31% of my performers in the top 2% of the rankings. What's going on here? What's happening here? I'd suggest to you there's 2 things happening. It has to do, first of all, with signal-to-noise ratios, and second with something called AIM defines a system. If you hung around with Ed Deming, this was a little bit of a mantra with him. The purpose that you're trying to achieve determines the system that lies behind it. Signal-to-noise ratios, very quickly. Walter Schuhart was actually Deming's mentor. He talked a lot about complex systems, demonstrated that any complex system always contains an element of random variation. I won't go into the science of it. It's a scientific phenomenon. Well, measurement itself is a complex system. It turns out that any time you're evaluating performance, you're always looking at the performance through the lens of a measurement system. And both of them contain variation. Now, if I were doing formal quality theory, I'd talk about what's called gauge theory. To an engineer, a gauge is a measurement device. It's called measurement system evaluation, but you have to assess those together. How much of the measured variation arises from the process itself as opposed to the measurement system through which one views the process? Yeah, now it's an interesting little fact, speaking as a statistician. Imagine that I'm tracking those data and I find a statistical outlier. One member of the group I'm assessing that's a statistical outlier. Exactly what does that mean? Precisely what it means is if I track that point to its root causes, with very high probability, I can find the legitimate cause of the variability. And that's all it tells me. It just tells me that if I go hunting, I can find the cause with very high probability. Well, to make that a little bit more real, this idea of signal versus noise. Back in the day at one particular large system, we were building clinical registries with a fairly complete set of carefully selected clinical and cost outcome data for purposes of managing and improving clinical processes, far beyond anything that you can even come close to with claims data. But we knew this phenomenon about gauges. We knew that you're always seeing the processes you're trying to manage through a measurement system. We found lots of outliers when we initially deployed those carefully constructed quality measurement systems. But we were smart enough to track them back to root causes. Funny thing, about 30 to 50% of those initial outlier points track back to the measurement system, not to the underlying process. What do? You use the outliers to find defects in the measurement system, then you systematically improve your measurement system. Guys, I can tell you, they're just weird. Some of them are, you never would have anticipated them in 100 years. And then you hit reality, comes and slaps you in the face a little bit. That's how you learn how to build a good measurement system, is by feeding it back on itself and reducing the amount of noise in your measurement system so you can clearly see what's happening in the phenomenon you're really trying to observe underneath. See that idea? I've never met somebody who's smart enough to get it perfect the first time. This is a way of building an experience, measured, thoughtful experience, so that you can proceed ahead on a more firm foundation. Now, the second idea, AIM defines a system. This is an article that Don Berwick and Molly Coy and I published back in the run-up to the NQF. We were on the Strategic Framework Board, and we published an article in the journal Medical Care on this. Don actually generated the graphic. We pointed out that there are two different aims for quality measurement. And the one on the left we called selection. They're judgment systems. Who's good versus who's bad. The way you really distinguish this one, it focuses on the person, a physician, or perhaps a corporate person like a hospital. Your aim is to rank, really, so you're interested in results on performance for selection and accountability, knowledge about performance, really targeting as your end customer, consumers in their various forms, purchasers, regulators, patients, contractors, referring clinicians. We stood that in contrast to pathway 2 for change or improvement. The difference with that one, instead of focusing on person, it focuses on process. It assumes it's not a matter that when you get a particular person, you automatically get kind of bonded at the soul, a particular approach, that people can change. This one assumes that improvement's possible. It's not a matter of selection so much as it is a matter of change, you see. It's interesting, the data systems are really different. When you focus on that side, you don't really measure performance at a person level, you measure it at a process level. And it redefined transparency. Twice at IOM, we've studied transparency and come up with a very different definition, where it's really in that interaction between a patient and a clinician as choices are made. That's where you really need transparent information, and nearly all of the information is process level data, as people make choices about their care going ahead, you see. Now, selection systems make a series of assumptions. I won't go into the technical details, just don't have the time. The first is that they can accurately rank. There are some instances where they can, they're rare, as it turns out. When you carefully assess measurement systems relative to their ability to accurately rank, it requires almost perfect data, and you just don't get it. They have massive, wide confidence intervals when you hit the statistics right, even for validated measures, where a 95% confidence interval can contain almost the full ranking scale. I could either be number 1 or I could be down at the 20th percentile. Statistically equivalent for most of these measurement systems. Number 2, there's a belief that consumers will respond. We studied this at IOM in the Performance Measures Subcommittee that Elliot Fisher and Don Berwick chaired. Turns out that patients rely almost exclusively, 2 or 3% do not, 97, 98% rely on their relationship with a trusted advisor, in the person usually of a physician, as they make choices. They rely on stories from a trusted advisor, not on statistics, massively, and making choices. This is a little throwaway that if people did move, there's sufficient good system capacity, there's not. And then the idea that poor performers will respond with real improvement. That turns out not to be true either. Yeah, top-down selection measures usually do not include all essential data elements. They particularly miss critical cofactors. I cannot interpret a hospital's CAUTI rate, catheter-associated urinary tract infection rate, without knowing their culture rate. Dramatic differences in reported outcomes depending upon how often you culture. And that's just one simple example among a very wide array. It's not just the measure itself, it's the framing of the measure, to understand what it means and interpret it correctly. They consume huge amounts of resources. A report out this morning from the AHA, $39 billion on administrative costs associated with regulatory compliance. About 1,600 measures for a typical hospital required to report. What it does is take all of the resources. It's the idea that quality is regulatory compliance. What's my minimum investment to pass muster with the regulators? What it does is suck all the money out of actual improvement. Seriously, grand examples of this one running around, leaving no resources for actual management and improvement. Selection measures imposed in the name of accountability for quality can block improvement and actively damage care quality, is the key takeaway. Measurement for change and learning, very different, generates very different data sets. It actually tolerates bias in the data. You only have to be able to tell if it's getting better or getting worse, and it tolerates much dirtier data for this particular use. It tends to be very parsimonious, properly constructed. You can blend it into clinical workflows. It tends to be the information those clinicians must have to do their work. If you carefully design it into workflows, that minimizes burden. The funny thing is it contains selection measures. If you build a system for that purpose, you'll get some of the most robust selection measures you could possibly imagine. On the other hand, it's a one-way street. If you build for selection, you don't get change, improvement. But if you build for change or improvement, you get a fairly robust set. But it takes more work. It takes more science. It takes more discipline. You have to be willing to step up, even though you're in a regulatory position. Yeah. Now, the last little bit, Deming made a common comment. I said it often. It's been validated by many others since. When you get pressure to meet an external target, there are three things you can do. You can improve the system. That takes time and real resources, some real leadership. Number two, you can suboptimize the system. So what you do is you take resources and focus them under the spotlight. The real story, when CMS Hospital Compare came out, hospital in Utah, a major academic center, put PAs in the ED 24/7. 3 of the major 4 subclasses of measures were tightly associated with ED. They used a PA because they could sign a note and have it count, and they could write orders. And they shadowed the regular ED team to buff the measures for pneumonia, buff the measures for MI. And it worked. They got slight improvements in their measures out of the ED. The question is where did the PA come from? Did it just magically, 24/7 PA coverage, drop out of heaven? Was it free? Good heavens, no. The budgets didn't increase. They got pulled from other areas. And overall quality of performance of the system declines when you concentrate resources under the spotlight. Very common phenomenon. The last one, game the data. Now, the polite way to say that is you improve your documentation. Well, Deming's whole point, and many others since, as pressure to make the number increases, reliance on methods number 2 increases disproportionately. And at the same time, this is actually probably the worst thing. We don't have time to go into it. That external pressure destroys intrinsic motivation within professionals that are primarily dedicated to patient care, not to the money, frankly. Just to show you that it's real, this is Greg Fonerow at UCLA. We saw dramatic shifts, what we call range compression, around measures imposed by CMS upon the country. People published this and argued how much quality was improving in the country. Most of those measures in Hospital Compare, I did some of the studies, they were designed around mortality rates. And Greg pointed out that we should have seen dramatic differences in mortality rates in association with these dramatic changes in performance on the measures. Oh, no changes in mortality. In fact, we now have, for example, that recent report suggesting that the readmissions program is producing higher mortality rates in heart failure patients. It's almost certainly true, by the way, unintended secondary consequences of people trying to make a metric. It's amazingly common when you start to look at a measurement system this way and track it carefully. Just a few recent examples. The whole VA waitlist scandal is a classic example. No Child Left Behind, those teachers going to federal prison in Atlanta. Classic example of game the data under this sort of a system. Wells Fargo Bank credit card scandal. I keep a little list of these. It feels like it's endless. I'm sure it's finite, but wow, you can find lots of examples of these things on a broad scale, you see. What I'm suggesting is the measurement system is critical. Given the complexity of clinical care, Any legitimate clinical outcomes measurement strategy will always include a mechanism for data system validation as an audit system and data system feedback. And at least to date, I haven't seen them. It's not something that the leadership of our system have been willing to create, invest in, to understand. With that, Helen, I'm hoping that you'll really give me a good argument the other way, given your recent role at NQF. So here's the plexer.